Hello, my name is Dr. Dewan S. Raja. Today I will discuss about acute pancreatitis. Acute pancreatitis is the acute inflammation of the pancreas. Acute pancreatitis is a reversible inflammatory disorder of the pancreas associated with activation of pancreatic enzymes. We know that pancreas has exocrine part and endocrine part, and the exocrine part secretes some enzyme that goes through the pancreatic duct, unite with that of the common bile duct, and opens into the second part of the duodenum. So there will be activation of pancreatic enzyme like pancreatic lipase, amylase. There will be autodigestion of pancreas that may happen if the passage is blocked. Then there will be collection of the pancreatic juice rich in pancreatic enzyme that will start autodigestion of pancreas, and there will be some autodigestion of the surrounding tissue. Fat necrosis to hemorrhagic necrosis, deposition of calcium soap over the pancreas, sometimes formation of pseudocyst because this cyst is not lined by epithelium, rather it is lined by the pancreatic parenchyma covered by fibrous tissue. Incidence of acute pancreatitis is 10 to 20 per 100,000 in Western world. So in that case, it is not uncommon. So 10 to 20 per 100,000 people in the Western world suffer from acute pancreatitis. What are the causes of acute pancreatitis? Alcoholism, gallstone obstructing the pancreatic duct, usually small gallstones. Okay, hereditary pancreatitis, trauma, abdominal surgery, ERCP, endoscopic retrograde cholangiopancreatography, medication like that of anti-cancer drug, anti-gout drug, as well as the diuretic drug may cause acute pancreatitis, mumps, a viral infection that affects the parotid gland, that affects the pancreas, that affects the gonads. Okay, metabolic disorder like hypocalcemia, ischemia. It may be idiopathic. We don't know the cause of acute pancreatitis sometimes. Okay, this is the pathogenesis that is taken from Robin's pathology. We have duct obstruction. This is the common bile duct. This is the pancreatic duct. So there may be some blockage here, and there will be stagnation of fluid here. And these are the asyni of the pancreas, so that may be damaged or destroyed. Okay, here SNR cell injury, alcohol, drug, trauma, ischemic, virus condition, release of intercellular proenzymes and lysosomal hydrolase. Ultimately, we'll have SNR cell injury, like defective intercellular transport. Okay, so they all lead to SNR cell injury, activated enzyme. This is the enzyme. There will be acute pancreatitis. Okay, if we go to the acute pancreatitis, what are the clinical features? Acute abdominal pain radiating to the back. It is a severe pain, guarding, and hypoactive bowel sound. This may be the sign of peritonitis, the beginning, shock and confusion, fever, tachycardia, respiratory distress, jaundice, ascites, that is collection of fluid in the peritoneal cavity, hypocalcemia because calcium has been utilized around the pancreas, Chauvet sign. So if we tap here, facial muscle will react, and the Trouser sign, if you add a blood pressure cuff and if you hold it just above the systolic blood pressure for 3 minutes, then there will be flexion of the wrist, flexion of the metacarpophalangeal joint will happen. Okay, and also we get acute pancreatitis, intra-abdominal bleeding, like Cullen sign around the umbilicus. Umbilicus will get bluish sign, gray Turner sign. Okay, that is present around the loin area. We'll get some ecchymosis of bluish color. These are indicative of some intra-abdominal bleeding. These are two features. Okay. In acute pancreatitis, what should be the diagnostic workup? Certainly pancreatic enzyme study, serum amylase, serum lipase. Imaging study like abdominal plain film, CT scan of the abdomen, MRI of abdomen. Treatment? Nothing by mouth, NPO, nasogastric suction, allergic for pain, analgesic for pain like even morphine, pethidine. Correction of metabolic abnormality like the calcium, antibiotic if there is any infection, surgery in gallstone, perforated peptic ulcer, necrosis or infected foci. If we have that over the pancreas, then we need surgery. Surgery has very limited role. Role is this. Patient is managed through this. Surgery is secondary. It has minimum role. In pancreatitis, chronic pancreatitis, progressive fibrosis of the pancreatic parenchyma, calcification, pseudocyst. Again, that cyst is not lined by the epithelium. It is lined by the fibrous tissue and the pancreatic cells. History of alcoholism, history of abdominal and back pain, pancreatic insufficiency, diabetes mellitus, tituria, fat, there is fat malabsorption, like vitamin A, D, E, K is not able to absorb, deficiency of fat soluble vitamin. Okay, vitamin A deficiency causes what? Night blindness. Osteomalacia, yes, vitamin D is not absorbed properly, then there will be osteomalacia. Hemorrhage, it is related to vitamin K mostly.